On the behalf of APSP, I welcome all the three presenters. So Daniel Von Allmen, Todd Ponsky, and Arun Garrison. All three are pediatric surgeons, and they are working at Cincinnati Children's Hospital. And I think we must go for the presentation as we have enough participants who have joined. So Garrison, can you please start the presentation?
So I just want to make one just introduction statement. I just recently joined Cincinnati Children's about 2 years ago. And before I came, I loved doing esophageal atresia. I was very fortunate to have been trained by Rothenberg on the more minimally invasive ways. And I felt like I had a really good skill set and understanding of esophageal atresia until I went to Cincinnati Children's and I saw what the real experts do. They have an esophageal center there that blew my mind and made me feel this big. They meet every week with a huge group and they go through every case from the simple to the very complicated, involving an entire airway team and a GI team. And Aaron Garrison, who you're going to hear from, has become really the leader in the minimally invasive thoracoscopic approach and advanced esophageal repair. Dr. Von Allmen is our boss, who is the absolute expert and really is the one who handles the most complicated, difficult, challenging cases. He's the one that they all go to. So I felt these two are the absolute experts to be talking about this. And I was excited that they are going to be leading this discussion today. So thank you for inviting us. And I'm going to turn things over to Aaron.
Thanks, Todd. And I know I speak for you and Dan in appreciating the opportunity to talk with you guys and also learn from you as we go along. So please, I know there'll be time for questions at the end. We do have a lot to cover, but if there are any questions, we'd be happy to answer them throughout the discussion. So we were hoping to go through quite a bit. We'll briefly touch on some background in anatomy as well as newborn management. We're going to go into operative planning. Naeem had asked for kind of pitfalls and tips and tricks about esophageal atresia repair. We'll do a little bit both open and thoracoscopic. And then we will hopefully get into some of the post-op complications and options to treat those that we have. Some discussion on long gap esophageal atresia, and then outcomes and follow-up. Many of you I know are familiar with the Gross classification. Most of our discussion is going to be based on both the type A and the type C esophageal atresia, with type C being significantly more common and type A being the second most common. I'm sure the incidence in the US is about 1 in 5,000 births. And interestingly, recurrence among siblings is about 0.5% to 1%. We always go through this with trainees and things, not because it's something to memorize, but because it does actually guide our workup in the newborn period. So we always kind of go through the factoral association, which includes the spine, vertebral, anorectal malformations, heart, tracheoesophageal fistula, and then renal anomalies like our patient here. And then remember that in order to be truly considered bacterial, you need to have at least 3 of those present. So just having 1 or 2 doesn't technically count you as bacterial. Very important when examining the newborns, needs to be a full body exam, including the anus, because all of these things come into play as far as prioritization. And really the focus in that first 24 hours is trying to find things that are at risk of the baby's life. So getting an echo, making sure there's not a critical coarctation or a severe congenital heart disease. Renal ultrasound can be done before the baby is discharged. And then I put in this about the spine films because in our hospital, you have to get the ultrasound before the baby turns to be 3 months old. Otherwise, an MRI will be needed because they're too big to see the appropriate windows to the spine. did want to talk back about some the Waterston criteria, just to also hear from you how things are in Pakistan, but to point out that we still have a lot of work to do with some of the sickest patients with esophageal atresia. So for instance, when this study was brought up, babies who were weighed less than 2 kilos and who had severe cardiac anomalies, only 65% survived. And this was updated more recently. And really, the smaller the child, the more unhealthy the heart, the risk of survival really diminishes dramatically. And even, a quarter of those patients survive, which I think sometimes surprises the cardiologists and the cardiac surgeons who may not appreciate what a morbid disease process this can be. We wanted to start with kind of a case presentation. This is a pretty classic case. So this baby weighs 3.5 kilos, so is a good sized child, not able to take feeds. And as the nurse tries to pass her a Progol, this is the X-ray that is returned. And so I think you can see here that the tube is coiling in the esophagus, and importantly, there is air below the diaphragm, so the stomach is distended with air. Most commonly, this is the type of anatomy that you're going to see. So in our hospital, we would get the studies we talked about, primarily the echo, try to find the aortic arch side. And then as part of our standard workup is a pre-op bronchoscopy. And I like this picture, and I hope you can see my mouse, but the location of the fistula really kind of gives you an idea about how far you're going to have to mobilize that distal pouch to get an anastomosis together. So I would describe this as like a trifurcation kind of fistula. Did just want to show one of our standard pre-op bronchoscopies. A lot of these are done by our ENT colleagues. It's pretty standard for them to be involved with the bronchoscopy. And you can see they take out the endotracheal tube because it's very important that the patient is spontaneously ventilating while being evaluated. And I think you notice a couple things. One, their fistula is there about 1 to 2 centimeters below above the carina, pretty classic kind of location. But then the posterior wall of the trachea is collapsing. So just noticing the tracheomalacia that this patient has. And we'll get into more of that a little bit later.
Hey, Aaron, do you want to mention the issue of associated airway anomalies? Because that's what we think is an important reason to do the preoperative bronchoscopy is that we found a relatively high incidence of associated clefts, even if it's very small, like a type 1 cleft. And so we specifically look for associated airway anomalies, which requires putting in an alligator clamp and testing the posterior wall at the level of the arytenoids to make sure that there is no communication there. And a lot of times we see referrals and they come in having had that missed on their evaluation. So something we think is important.
And this is just another controversial point. I'm curious with the audience, so please type it in the chat. I did not do preoperative bronchoscopy on my patients unless I had a real indication. It wasn't until I was taught by this group to start doing that in everyone and realizing the benefits. I'm curious. It says here, Akil says, we don't do bronchoscopy in all cases. Yeah, so I've been convinced, so now I do. And looks like here again, it looks like most of you so far are not really doing pre-op bronchoscopy. It's something to consider. But interesting controversy.
Yeah, I used to think the main reason to do it was to rule out a proximal fistula, right? So you can kind of tell from the X-ray that you're thinking it's probably going to be a type C if it's 85% incidence, but it really does give more OR planning and more importantly, the characterization of the airway. How's the patient going to behave post-op, and what's the severity of the tracheomalacia, stuff that we're learning more about. Also, if you were to do the bronch and you see this trifurcation on the right side, then that's going to be a challenging case. Those are very hard to sometimes separate from the right mainstem bronchus when you're doing the procedure.
A good question from Aaron. Akil wants to know, how often do you see a proximal fistula? I've never seen one, but I wonder, I bet you guys have. So Dan?
Yeah, I've seen them. They are very rare. So it's literally a handful in the 35 years I've been doing this. So it's pretty uncommon, but they do occur. But it is also possible to miss them with bronchoscopy. So sometimes when you get in there, and we'll talk a little bit later about the dissecting the proximal pouch off the trachea. I've certainly had cases where either there was a fistula or it looked like there was a near a sort of formed fruste of a proximal fistula where there was dense adherence between the proximal pouch and the posterior wall of the trachea.
Dr. Arshad did say that sometimes they will catheterize the fistula, and I should say that's not necessarily standard. It is sometimes helpful to be able to see and identify it, but I think there's some difference in opinion on whether it's needed or not, but that's interesting that your anesthetist can do that for you. So if you're getting your echo, this is also a controversial topic, and they find that the aortic arch is on the right side. I'm curious what others would do. Would you choose to go into the right side, or would you try to approach the repair from the left? So, and the research has shown that there really is no difference in establishing continuity or in morbidity and mortality. But if anyone has any comments on that.
A classic teaching when I trained a long time ago was that you always approach these from the left, but having come across several that were not diagnosed preoperatively, it is certainly possible to do the anastomosis from the right and mobilize the proximal pouch.
So before we get into the double aortic arch question, which was just asked, Dan or Aaron, it seems like we've had a slew of these in the past year, of these right-sided arches. I still can't decide right now which one seems to have been the easiest. I've done both. Dan, I don't know, you probably have had the most experience, although Aaron, this year you've had a bunch. What would you say right now? Do you think going on the right is where you would go? And how do you decide?
I think thoracoscopically, it's easier to do from the right. That would be the way I've changed my management is now doing these thoracoscopically. If there's just less in the way, and you just have to know where to look for the proximal pouch.
Yeah, I totally agree. I think early on, it's sort of nerve-wracking to try to decide which way to go because you're worried about not being able to find it. But with the scope, and I think we have some pictures.
Yeah, I was just going to say, this is great because I've always imagined it, but this is a great video to show you what it looks like from the right side if there's an arch. So
go ahead, Todd. This was your patient.
Yeah, so this was a very interesting case. This was a child that had a right bronchial fistula. It wasn't to the trachea, it was to the bronchus. And so here we are with a bronchoscope seeing the bronchus into the fistula. So there's the fistula, and you can see the aorta above us, so you can see the view. So that's, Dan, I can't believe I haven't ever point blank asked you that before, but that's exactly right. With thoracoscopy, that makes the difference. You can see how you can kind of lift the aorta up, and you actually can see it. And we did the whole case this way from the right side. However, you do have to manipulate the aorta quite a bit. And this morning in a conference with one of our colleagues, Dr. Garcia, he was noticing that every time he was manipulating the aorta, he would get a flow problem. So that is a thing. You do have to move it out of the way. Hey, Dan, have you ever thought about putting just like an aortopexy, sort of an adventitial stitch on the aorta to sort of pexy it away, I wonder, or Aaron, so that you don't have to use one of your hands the whole time holding up the aorta? Do you think there's enough safe adventitia to tack it up a little bit?
Right. My question would be, what are you going to tack it to? Because you want to hold it medially, and you can't tack it to the hilum of the lung. So I have not is the answer, and I think it's because I don't know it's an interesting idea, but I've never tried that.
What we ended up doing with Dr. Garcia's case is just putting in an assistant port to hold the aorta up and away, so more inferiorly. And then why not go from the left side if you have a right aortic arch? I think those are it's okay. I think the point is that there are two good options. You can choose what you're more comfortable with. I personally have become more comfortable going on the right side just because now we see the anatomy a little bit better and I kind of know where to look, but I think it all depends on experience. So this is one of the most important things. I know Professor Broey will probably agree that the positioning of the patient is the most important thing when you're doing these. And now, so first going to just talk about doing them open. I think everybody knows usually left lateral decubitus, but we always really have a discussion with anesthesia about a few things. One, they don't need to do lung isolation or try to selectively intubate either side of the bronchus. They need good access, and it needs to be flowing once you've actually positioned the patient. Arterial line is usually necessary, especially if you're doing thoracoscopic. And then we always, we have a rule of like having them suction the endotracheal tube at least every 15 to 30 minutes, because it's very common during these cases to have a clot obstruct the endotracheal tube. They lose end tidal, and they're looking up at the OR screen thinking that it's something that you've done, when really it's a ventilation issue. I'm sure many of you have experienced that.
Yes.
And then finally, the tube migration. So that pouch can, the tube can migrate into the pouch if it's above the fistula, which is scary to sometimes tell the anesthesiologist to pull back the tube a few centimeters. Any comments on that?
Professor Brohi, were you going to say something?
I think one of the important thing in success of thoracoscopic esophageal atresia is, like you said, the positioning. I think when I started 10 years back, I used to go with the pure lateral, and then I felt that I was having difficulty in access to the upper and lower pouch. Then I started, nowadays I'm doing with the prone position, almost prone. So in this way, the anesthesia problem what I have faced in the initial period is now decreased. The lung is itself down without any giving pressure. So you have got a good access when you are in a prone position. I think this is the great success when the anesthesia people are also comfortable with this. So giving also the low pressure and having a more comfort for the surgeon. Yes.
Yeah, I agree completely. And I think that those who have kind of started to try doing this, they kind of don't go as prone as you really need to go, and then your visualization is not as good, and then the case is much more difficult than it should be. But it takes a lot of, I don't know, it takes a little confidence to really put the baby semi-prone. So we have a few pictures of that here. Just really, you can see how anterior the baby is pointing. And we also move them up to the corner of the bed, as you can see in this bottom right-handed picture, where so that you're looking at the monitor across. And then if you can see my cursor, this dot in the armpit usually ends up being our right-hand port. The camera goes just off the tip of the scapula, and then the left hand does here, and the little inferior to that.
And I want to stop and point that out again, because Aaron taught me that. I used to put them just on the side of the bed. That's how Rothenberg taught me, to have them pretty much almost prone, as Professor Brohi said, and I stand on the side. Aaron puts them on the side, but at the corner top of the table. So you have a 3/4 of the space to operate on, because they're pointing at the top corner of the table. So you can have almost 3 people around the baby, which makes it really nice and easy.
There's a nice paper out of the Netherlands, Dr. van der Zee, who kind of went through some of the error traps in the procedure. So just a couple of reiterations that the esophagus is very posterior mediastinum. That's why the position in the prone position works, because you actually can get behind the vertebral bodies there. If you're having trouble identifying, you can find the vagus nerve, which acts as like a racing stripe and comes along on top of it. One reason to have the bronchoscopy is to kind of have an idea in your mind about how high or low the fistula may be. And just a demonstration of getting around the fistula, usually with a vessel loop, finding the azygous vein and separating it there. And just a live shot at the vagus nerve as a way to help identify the esophagus. Not because everybody's doing these thoracoscopically, but I think the best way to really visualize the anatomy is thoracoscopically. So I wanted to show just kind of identifying the azygous vein and how it can be a marker for where the distal fistula inserts into the trachea. So you can see the azygous vein crossing, and then a little vagus becoming apparent there. And we were going at the esophagus there. I'm going to go to the next video for the sake of time. So this is a brief video of kind of the main steps of the thoracoscopic repair. First, you can see we get underneath the azygous vein. We've been using the I'm sorry, not the ligature, the Just Right, now called Cool Seal, I believe, to kind of help dissect that and then also seal it. We'll just let this play for a minute.
So while you're letting it play, Aaron, this is a 3mm sealer by a company called Boulder. It's a really nice trick. The other thing I really want to repeat again, what Aaron said, one of the stressful parts of the thoracoscopic approach is that you're not positive you see the distal esophagus. That vagus stripe will always lead you to the esophagus. It lays right there. So find the vagus and you'll be able to see the esophagus.
And if you're struggling to find it, go distal down toward the diaphragm, because we've done that several times. Is go find it low and follow it back up, because it can be really hard to find, especially in those trifurcations.
I'd say one of the things we don't love about the thoracoscopic approach is depending on a clip or two to seal it. And we do hear or see of clips falling off. So I don't know if anyone has any other ideas about that. I'll let this play for a minute. So once it's ligated, usually then anesthesia can take a deep breath. They're a little less worried about ventilation. And we will ask them to use a Repogel to gently push at the distal end of the pouch. I'm sure that's how most of you do as well. But it really helps you separate from the surrounding tissue and identify where to start your dissection.
One question was where you put your ports. I don't know where Aaron puts them. I put mine just anterior to the tip of the scapula. And then I put, then I go anterior up in the axilla and then a few rib spaces down. So it's a triangle, tip of scapula, axilla, and then down lower on the chest. So Aaron, you're having anesthesia push something down here?
Yeah, it's just a Repogel that they're putting tension on, so that you can see that when they do that, the tissue is just a little bit easier to separate. And then when you can move it back and forth and kind of get different planes around with counter tension. So this is when we are ready to start our anastomosis. We usually wait, just leave it clipped until we've dissected proximally and make sure that we have enough redundancy to do our anastomosis.
Can you hit pause for 1 second? So I do something different than Aaron here. A trick that I learned from Yamataka in Japan is I don't cut all the way through the esophagus. I cut 90% through the esophagus so that it's still attached. I put that way it doesn't retract down. I can put my first stitch and then I complete the cut.
The other option for that, which I learned from Steve Rothenberg, was he puts a stitch maybe a ½ centimeter back on the proximal and distal pouch and pulls them together and actually pulls that stitch out through the chest wall. And if you can't get them together, then you're not going to be able to do an anastomosis. For him, it's like a test of will this fit or not, but it helps to hold the two ends together.
That's what that's interesting, Todd. That's what I ended up doing, Dan, with this one, is just trying a sort of tension stitch. And I think it worked okay, but maybe just I'll try the other way next time. And then for the trainees, this is something that we always do just to rule out a distal esophageal process. 2 reasons. One, to make sure that there's not an obstruction distal to the anastomosis, but 2, it makes it easier to sew the anterior wall of sutures with a tube in there. And that's always one of my favorite parts of the case, is just seeing it go all the way into the stomach.
Aaron, there was one question that is so important. I'll tell you, because when you're doing this thoracoscopically, you're a little disoriented if it's new, and even if it's not new. Even for me, I've done quite a few. In fact, this is the way I usually do it, and I still sometimes get worried. Am I looking at bronchus or esophagus? And that vagus stripe, the question is, what does that vagus stripe look like? So if you see it, Aaron, I want you to show, because it's really easy to see. It's actually part of only anatomy that's super easy to identify. So if we see it here, he'll show you. There it is, actually. So you see the vagus there? That's a beautiful view. It's really, if you look for it, you'll see a white stripe. It's always there.
I think just I'll move ahead last, but
But wait, I think, did Professor Brohi, did you have a comment or question?
I think for the proximal and distal stitching, what Todd have said that he is nowadays cutting 90% of the distal esophagus to make it stay there. I agree with that, because sometimes what I do is, when I do thoracoscopic, I assess by pushing the tube from above and then see what could be the distance between upper and lower pouch. If I see that the distance between two is quite higher, then I don't cut whole of the distal esophagus. But if the distance looks like more, then I cut 90%, and like this, either I cut 90% or I make a stay suture first between upper and lower pouch, so that the both end could be stay close together. Because the first stage is the prime stage, which is the key for the rest of the repair. So I agree with you, Todd.
I'm going to keep going because we have a lot of things. So the other point we wanted to make, having seen other patients from around the country who come here, is sometimes the surgeons will leave a long piece of esophagus when they've come, so a diverticulum of the fistula. And this can lead to problems long-term, such as this CT scan here. You can see the right main stem, the left main stem, and then there almost looks like there's a third structure that comes off here. And then down in the lower picture, you can see just kind of a chronic appearing abscess due to aspiration, and usually like bacteria and things will just pool in the pouch and then seed the lung. So those kids can show up later on in childhood. The other things wanted to touch on in the next slide are, and Todd admittedly is the one who taught me about this part, is that the esophagus and the trachea really are adherent to one another, almost as if they have a common wall, like when you're doing an anorectal malformation. And Todd, do you want to take this part? You like talking about this?
Yeah. So this I actually learned from Sean St. Peter, that so if you look at it, we think of it that the esophagus, that the proximal esophagus is sort of laying on top of the membranous trachea. But the way I think of it is it's almost actually like this. It's not really like this. It looks like this, but really it's this. The most adherent part is the very tip. And we go, oh, let's go right at the tip. But actually go behind the tip. And I see Professor Brohi nodding his head, but you go behind a little bit, and that's a much easier plane to dissect into, and then dissect up, and you'll see it'll go like this, and then you can take that at the end.
So we have a couple open pictures here that demonstrate that. And as Todd said, just at the very distal part is where it's flush, and you can really get into the trachea at this point. Other few things demonstrated here, the vagus nerve, the fistula here, and then the repogal. But the common wall is the part that we wanted to point out because it takes a while to sort that out. And then this is as we've begun to separate it, and the fistula has been closed with sutures. It's also sometimes pretty striking how close together the two suture lines are. So the esophageal anastomosis and the tracheal suture line really can be right next to each other. So if there is tissue or a piece of vein or anything that you can do to interpose in between the two, we think that may decrease the likelihood of a recurrent fistula.
Be curious to know if folks do that, because I was never taught to do that on a primary repair. And we'll probably talk about it later, but I think this is a great time to think about a posterior tracheopexy, because that will absolutely separate the suture lines.
This is just the completed process. There's a little bit on the end about this, but we always will leave a chest tube. We've been involved in a study now showing that by leaving an anastomotic tube or an NG tube, there may be a higher stricture rate. But I'll be honest, I really like leaving a tube behind. That just kind of gives me comfort to do that. But I've been convinced by my partners not to anymore for the type C. So I don't know what you guys do standardly, leaving chest tubes, leaving transanastomotic tubes at all. And I agree with what Todd said about when you start insufflating anesthesia, usually the baby will desat. It usually takes just a few moments to let them stabilize out.
The transanastomotic tube is a huge change that happened rapidly in the United States after a very large study by many children's hospitals together that switched my practice, that if you leave a tube at the end of the case, they actually have higher stricture rate than if you take the tube out at the end of the case.
Last thing is Naeem asked just a few tips and tricks of problem solving. So when you're mobilizing the proximal pouch, the recurrent laryngeal nerve lives up there. And so a lot of traction or hook cautery can cause injuries or traction injuries to that. We talked about the common wall already. If you do identify a hole in the trachea, just try to repair it with some suture and potentially cover the suture line. If you're doing it open and there's tension, one thing that I was taught is that the end sutures at the sort of 3 o'clock and 9 o'clock sutures, you can place those sutures, not tie them, but cross them and kind of bring them together so that you can complete the back wall of your suture. And then as you're doing your anterior wall, there tends to be less tension. As Dr. Von Allmen mentioned before, mobilizing all the way down to the diaphragm can also give you a few extra millimeters. And then what do you do if you still can't, after all of these efforts have been done and you still can't complete the safe anastomosis? And Dr. Von Allmen, you want to chat about this? Because I think this is a video from one of your talks.
Yeah, sure. This actually was described by David Vanderzee. It's sort of a modification of a different technique that we'll talk about in a minute, but you can put these slip knots in the proximal and distal pouches and try to pull them together. Historically, what I've done, if I couldn't get it together, I would put the ends on tension and then put them, tack them to the prevertebral fascia. But with these sutures proximally and distally, especially if you're doing it thoracoscopically, you can pull the two ends close to each other, and then that second video is going back several days later with less tension to complete the anastomosis. So it just allows you to pull, hold the two ends of the esophagus on tension, and David is adamant that it's not growth but stretch that occurs over the first few days, but that will oftentimes provide you with enough distance to go ahead and complete the anastomosis. What I've done wrong is to wait more than a few days, and then you get in there and there's lots of adhesions and things are stuck, and it becomes a much more difficult procedure to do thoracoscopically, and I've had to convert to open procedure on a couple of kids.
And, you know, I think even if seeing this with the scope is just demonstrating that you can do the same thing open if it's not coming together, just tack them with the silk suture. And you've told me in the past that sometimes those silk sutures will just fistulize and you may develop an anastomosis if they're close enough.
Yeah, I actually recently reviewed a paper where silk sutures were used to pull the two transmural silk suture figure of 8 stitch was placed at the esophagus, and after 10 days, I don't remember the exact numbers, but it was something like 60% of them formed an autoanastomosis, which they then dilated. And we've had at least 2 cases of that happening here, where all of a sudden the child started vomiting their 2 G-tube feeds, and with great surprise, we studied the child and found out that they had essentially autoanastomosed because of the stitch across the 2 ends.
Okay, I think we're on to our second case here.
So I'm going to talk about this a little bit, and this is like the first X-ray. This is something that I'm sure everyone's familiar with, but when you get the curled NG tube in the proximal pouch and no gas in the abdomen, then that obviously is indicative of potentially a type A deformity or a type A esophageal atresia. And these patients are relatively uncommon. I think you can go to the next slide, Aaron, but only 8%, so less than 10% of cases, but they are definitely the ones that can cause the most challenge in terms of ultimately establishing a path from the mouth to the stomach. This just shows the difference between the type A and the type C, and the International Esophageal Society has defined a long gap esophageal atresia as one in which there is no air in the abdomen on the initial films. Our typical management is we take the patient to the OR, do a G-tube. Sometimes we will actually do a gap study right there at the initial trip to the operating room, depending on the size of the patient, where we put something metallic in the distal esophageal pouch and something down orally, the NG tube or something else, and push down to try to get an assessment of the gap. This one you can see by the arrows there are 4 or 5 vertebral bodies. And then our typical approach is to wait. And we wait for several weeks, and we'll take the child to radiology every 2 to 3 weeks and do a formal gap study. And as this exam shows, you know, there's a lot of inconsistency when people talk about the gap. It's unclear because people measure them differently. It's some people measure them on tension, other people don't, whether it's a radiology study or a mechanical study like this, but we tend to do both. So we take the patient to the interventional radiology suite, pass a Bake's dilator typically up to the distal pouch under radiographic guidance, and then a NG tube or some other radiopaque thing down the mouth so that we can measure the gap both off tension and on tension to see how much distance we actually are anticipating by the time we go to the operating room. We like to get the distance to be about 2 vertebral bodies. If we get it within that distance, then on tension, then we think there's a pretty good chance that we're going to be able to get the 2 ends together. There's some controversy as to how long people wait to see if the esophagus will grow. My personal view is that we will wait 6 or 8 weeks, but we don't wait. I've seen patients where sometimes people wait for months or longer to see if the esophagus will grow. And I think that there is some initial growth, but that doesn't extend beyond the first 6 to 8 weeks. Then there are the options if you can't get it together or it looks long are these options. There are a number of elongation techniques. The most well-known is the one that John Fokker described. I alluded earlier to David Van Der Zee's technique, which is similar, but has some significant differences from the Fokker approach. And then the Kimura, which is more historical, and I'm not aware of, honestly, I've never done that, and I don't know if folks have experience with that on the call, but I do not. And then obviously sometimes you just can't get the esophagus together, and you commit them to a replacement with either gastric colonic interposition or a small bowel graft. Next slide, please, Aaron. So the Fokker procedure, and again, I'm sure most people are familiar with it. Rusty Jennings has been a big proponent of this after learning from Fokker at Boston Children's. Essentially what it involves is putting these traction sutures in the proximal and distal pouches, bringing them out through the chest wall, and then on a daily basis going by and tightening the traction sutures until the 2 ends overlap, and then take the patient back to the operating room and do the anastomosis. I love the physiology of traction causing growth, which it certainly does in development with things like the cardiovascular system. So I think that the physiology works. It is a challenging, it can be a very difficult procedure. And if you go to the next slide, Aaron, this is the data table from the very nice paper that was reported by Rusty and the Boston group back in 2015. And you can get the esophagus together. They divided those patients into a primary group, which is where they did the initial procedure, and a secondary group that were referrals to them after the initial procedure had been done elsewhere. And I think there are a few, while you can get the esophagus together, there is significant morbidity associated with it. You can see in that first column of the primary case, 27 cases, that those patients spent an average mean of 2 months in the ICU and were paralyzed for 2 to 3 weeks. In the secondary patients, they had a ICU stay of 110 days and spent over a month paralyzed. And then one of the important findings for me was that they were able to achieve an intact esophagus in 96% of primary cases, so you can definitely get the esophagus together in most cases, whereas only 2/3 of the patients were able to achieve an esophageal anastomosis in the secondary cases. And then one other data point that is important to me is if you look at full nutrition, which is the line below those circles, you'll see that in the secondary group, less than 10% of those patients, only 2 patients ever achieved a full oral diet. So like many things with this patient population, there are lots of options. And to me, that means that none of them work very well because everybody would do the same thing. This is a technically challenging approach. The patients have anywhere from 3 to 5 to 7 thoracotomies, and that has long-term morbidity associated if not done thoracoscopically. So again, I'm not disparaging it. We don't have any other good answers for that, but I do like the modification that David Van Der Zee has proposed. So if you go to the next slide, Aaron. The International Esophageal Atresia Group has come out with recommendations, and they're the first choice for replacement of the esophagus, if it comes to replacement, is a gastric transposition. And the rationale for that is that there are arguably less anastomoses and that it is technically easier to do. Our GI doctors hate this operation because they say that the reflux is terrible, but it certainly works, and it is a very functional procedure, and it can be done minimally invasively with an incision in the neck and then a laparoscopic approach to mobilize the stomach and resect whatever distal esophageal stump is there. As pediatric surgeons, I was taught certainly, and I think many of us were taught, that there is no good replacement for the esophagus, and that all efforts should be made to preserve the native esophagus. This is a quote from Myers in 1974. And while philosophically I agree with that, I think that there are many cases where at some point it is appropriate to abandon the native esophagus and proceed with a esophageal replacement. Question, perfect timing on the question about reverse gastric tubes. Actually, I think we took the slide out of the reverse gastric tube that I had in here. That is another method where you use a sleeve from the greater curve of the stomach. I have not done that since my training, but that is certainly another approach. In Cincinnati, I was trained here, and our training was to use colon interpositions, and colons, they are also not a great answer. The problem with esophageal replacement is you're trying to pick the best worst alternative. And we do colon interpositions. We've had very good luck with that. I think there are some advantages to that, especially in some of these complex patients that we see that have had multiple operations elsewhere. And that is because if you get, you can get a very good blood supply that allows you to get a ton of length and put we've in some cases actually sewed the colon all the way up to the pharynx. And I think somebody commented went away that the colon is the worst alternative. I agree that there are not good alternatives. This is one that we tend to use. We do everything here. We will do gastric pull-ups. We will do colons. We have not typically done small bowels, which is the next alternative. Again, that's something that's been popularized. These are just pictures of a colon interposition, which I'm sure you're familiar with. One of the advantages is you can either put it through the posterior mediastinum or put it through the retrosternal space if the posterior mediastinum is scarred from many previous operations. So that is an additional advantage that we have used the colon for. The small bowel interpositions, the challenge with those is that they need to be supercharged from a vascular standpoint in the neck. They also, the idea of the small bowel is that they will not get tortuous and dilated. But we have seen a number of patients here who had small bowel jejunal interpositions and had to take them back for a median sternotomy to shorten the redundant graft. It can become quite redundant. This study again shows a picture of a colon interposition, but they do get dilated over time, and that can cause significant problems with emptying. They tend to get a sort of siphon deformity just above the diaphragm, which when I was trained, I was taught that those are very difficult to fix and that you'll kill the colon interposition if you shorten it. And that is absolutely not the case. It is not that hard to do a laparotomy on the child, go right on the wall of the colon to shorten it, and then reanastomose it to the stomach to straighten out that sort of siphon deformity that occurs just above the diaphragm. Aaron, are you going to talk about tracheomalacia?
Yeah, I think we've got a few minutes for it. We'll
Maybe just quick, yeah.
Quickly. So this is something, honestly, that I think we're learning more and more about, and you'll see some imaging, but I just mentioned this so that we can all think about it in our patients who are maybe not doing as well after the surgery as they should be. A pretty standard example would be this baby described here, who's a few months after his repair and has episodes of coughing, difficulty clearing secretions, and stridor, and maybe had to have some positive pressure placed back in at some point. So obviously a lot of this goes along with his esophagus, but we think this is under-recognized in many times. So tracheomalacia is what this baby had. It's just an example of a CT scan. I think it took a picture showing the flattened airway, so it becomes more eccentric. And I agree, Dr. Khan, that is something that we need to look into, is a recurrent TEF. So this is a post-op, post-esophageal atresia repair bronchoscopy looking for tracheomalacia. And we try to separate anterior from posterior as we can sort of help figure out what we're going to do with that information. And you can see in this picture, they didn't see any evidence of a TEF, but there was some pretty significant anterior and posterior collapse. I think they come back and you can see it. So fistula was there. They did not see a fistula, although I do see a little saliva that's pooling at the pouch. And as he pulls back, you can see the posterior wall and the anterior wall flattening. So that is part of our evaluation for patients like this. We're also getting into imaging some of these babies with MRI actually, and being able to kind of measure airway eccentricity and how it collapses with ventilation. So I think hopefully in the future we'll be able to have really good planning before we go to the OR, with maybe not even having to do the bronchoscopy, if we're able to get some pictures like this and work on that. So I already gave the presentation, so we'll hold on that, but a lot of these babies have a barky expiratory cough, and they may be triggered just by anything that aspirates into the airway. So it can be saliva, it can be just the physical process of both ends of both sides of the trachea stimulating the other side. And then many of them can have ALT or acute life-threatening events, which, as you all know, also goes along with reflux, which almost all of these babies have too. We always want to try not treating with surgery first. So medical things like if it's very mild, many of the babies will outgrow their tracheomalacia. So as the airway gets larger, there's less resistance, and they can just really essentially outgrow it. There are some medicines and inhalers that can help dry up secretions as well. We do try to avoid tracheostomy because that can also cause issues with fibrosis and scarring. And then we wanted to talk briefly about aortopexy, which I think is one of the more fun operations and satisfying, because you can see a difference before you leave the OR. In case you're not familiar, really the goal is just to move the aorta anteriorly to bring off pressure from the trachea. So part of that scope evaluation is to see where exactly is the compression anteriorly in the airway, and some have imaging like the CT shown here. Our favorite approach is through the left side, and we typically have to either push or dissect away or remove maybe half the thymus gland, which is the yellow structure, in order to find enough space to bring the aorta anteriorly. I have some pictures actually next. But one of the things we'll work up is get a CT scan to make sure that the aorta, there's actually space between the aorta and the sternum to elevate the aorta if needed. So here are just some pictures from the procedure. This is the thymus gland. Again, we're in the left chest here, and the head is to the right. And we, in the smaller children, will then find the area of the reflection over the pericardium, which you can see here. This is pericardial reflection. And we incise that with a scissor, and we try to get down to the point where the reflection really attaches to the adventitia of the aorta. Because then we don't have to put sutures in the aorta, but you really want to get back to that junction, because if it's just pericardium, it may fall away with some time. We will pass the sutures through the sternum and then thoracoscopically sew through there. And we will then try to get rid of that space by pulling up and tying the sutures underneath the skin. And we typically will have our pulmonologist at that point, come in and bronch at the end of the procedure, just to kind of make sure. And this is the same child. And hopefully you can tell that the anterior collapse is much better. There is some discussion about whether to do a posterior tracheopexy at the time of esophageal atresia repair. And I think what we've started doing is that if the pre-op bronchoscopy shows real intrusion of the posterior trachea, then it may be while you're there to put some sutures in the posterior wall of the trachea to the prevertebral soft tissue. So as one of the questions mentioned, can you think of a recurrent TEF? So this is an algorithm that we found from Montreal, I think, where if you have an EA patient with respiratory symptoms, the algorithm that they use, and most of us would start with a esophagram and make sure no stricture, talk about reflux. Does the patient need a Nissen? About half of our patients may need an anti-reflux procedure, although that even seems to be decreasing. Rule out a recurrent fistula. And then this is when we start looking into the airway and how severe is the tracheomalacia. Will that be helped by an aortopexy or not?
Aaron, there was a question about stents, and our experience with stents is that they work great while they're in, but as soon as you take them out, you're back to where you started. So we have not had good experience with long-term use of stents for tracheomalacia. We should probably call it here, because we got, I think, just a few minutes left, and would welcome any other questions or comments from our colleagues in Pakistan.
What I would do is in 2 sentences say Aaron was about to show that for recurrent TEFs, we use cautery endoscopic repair. And then the second thing is for long gaps, Aaron and Dan are now using magnets to bring the ends together. So we can answer questions, they can answer questions about that as well.
The magnets we found work great if you can't quite get the ends together, but you can pull them close together with stitches. Then you could put magnets in and have them create the anastomosis and then dilate it up after that.
Yeah, and there can be no fistula. It has to be either atresia or a fistula having been closed or ligated. Long-term complications of aortopexy, I'm not aware of any unless there's a phrenic nerve injury. I think it just may be if it doesn't help, then it's a big surgery to go through without an improvement. But I don't think there are a lot of known complications other than any thoracoscopic procedure on the left side.
We do not use steroids post-op.
But I just want to ask the audience, I mean, this was a big change, the endoscopic repair. I actually can't remember going into having to ligate a recurrent fistula since I started doing this. I used to use TCA, and now I use the Bugbee electrocautery. And after 1, 2, or 3 treatments, sometimes a few more, it closes. So if I can't get them closed, that's when I send them to Dan and Aaron to deal with. But usually you can treat these without opening the chest.
Yeah, I mentioned it at the beginning, but that recurrent fistula is a great indication for doing a posterior tracheopexy, because you divide the fistula, repair the esophagus, and then tack the the repaired part of the back wall of the trachea to the anterior spinous ligament, and it completely separates it from the esophageal repair. So we've had very good results with that, preventing further recurrences.
H-type, Aaron?
Yeah, I would say that's my favorite one. Those are the easier ones. The only difference being right chest instead of the left, like the aortopexy, and usually putting a repogal or some kind of tube in the esophagus so that you have something to dissect it free from the trachea. And then we've been using that 5mm stapler also from Boulder to usually just staple that common wall. But those are nice ones.
So you don't do those to the neck?
Depends on how high it is.
Yeah, it depends where the location of the fistula is, and usually they come through ENT some of the time, and if it's in the chest, then they will give them to us. But I know that they can be approached through the neck. That's a good question about how long does it take. I would say a couple hours of OR time. And it may be a little bit longer with the suturing. The suturing is the part that takes the most time, of course, but I think the dissection is so much easier, so much more visible, easier to see structures. I'm not sure,
okay.
Professor Brohy.
Also depends on the trainee.
I just want to say one thing here. So Aaron and I started working together, and he was like, I am doing these open. This is the better way. It's the safer way. I know it. And I said, please just try it a few times. And now he's just saying it's better view. It's a great way of doing it. It is so magnified. So what I would say is it will be quite longer your first few times, maybe your first 6 times. But eventually you will see the view of your stitches is so magnificent. And I'm sure others on here will agree that it's okay to do as much as you feel and then convert to open and do the rest that way. But little by little, you will get comfortable and it will be a very nice operation.
I'd like to hear Dr. Ali Raza. What's your assessment of that?
Professor Brohy?
Yes, I agree with Dr. Todd that once you start doing thoracoscopic, it's not like you do all the steps in one go. So if you are starting, then obviously the magnification is good. Then if you are able to ligate the fistula, this is your success. And then if you even if you are unable to do the anastomosis, leave it and then convert it. And then after 10 cases or 20 cases, you will be able to do the anastomosis. And then after 50 cases, this will be a piece of cake for you. So this is always a learning curve. So like I have done more than 50 cases, and then I have never opened for the last 4 years. So I found it that it's very easy to do anastomosis when you are in an expert phase. So I agree with the Todd.
Thank you, Professor Broden. Other questions?
Daniel, there are a few questions to the Daniel.
So, sorry, Naeem, go ahead.
There were a few questions to the Daniel when he was presenting. Can you please answer them?
Sure. I'm sorry. Some of them went by so fast I couldn't see them because I was looking at the slides. But I think one of the questions was about a pyloroplasty, and we do pyloroplasties on all of the colons, and the vast majority of the gastric pull-ups also get a pyloroplasty. So yes, we use pyloroplasties.
The other question that was asked to you, Dan, actually, let me answer one here, and then Dan, another question that was asked to you about how many stitches. Now, one of the funny things about thoracoscopy is because it's so magnified, the tendency is to keep putting stitches in because it's so magnified. And so usually it's 3 or 4 per side. It's usually about how it works. And the corners are the start far away from you. I do, because that's the hardest part, and then work towards yourself. But you'll end up putting more and more stitches in that you may not need to. It's also hard to determine thoracoscopically how far up on the esophagus to go because everything is magnified. You don't want to get too much tissue so that it tears. And then Dan, the question for you was about the length of time. You did mention a few days on the way you do it now with the internal traction sutures, but with a Fokker, how long until you usually go back in does it usually take?
Yeah, I will tell you, I am not the expert on the Fokker because we don't do that here. But the way it's described is to continue to go back and tighten the sutures until you get the two ends to overlap. The challenge is that frequently those sutures will pull through, and so you have to go back to the OR to replace the traction sutures. And I think that's the reason for the multiple thoracotomies in that group. But quite honestly, we don't do that here, and I would not pretend to tell you I'm an expert at it. I think that in David Vanderzee's approach, you put the traction, his initial description, not with the sliding knots, but the initial description was to put in the traction sutures, bring them out through the chest wall on some tension. You don't you don't change that every day, but you go back after 3 days. And I thought that's crazy. Nothing will happen in 3 days, but you go back after 3 days to break up the adhesions. And there are actually adhesions after 3 days to mobilize it, maybe retighten them if you can't get it together, and then go back 3 days later and put it together. And if you can't, then you have to take a different approach, either a longer term to wait 6 or 8 weeks, or just to proceed with a replacement. The magnets, there's a question about magnets. Aaron, you're the magnet expert, but theoretically they create the anastomosis within 4 days, but I think ours have been more like 7 or 8 or longer.
Yeah, I think the published data says about 6 days is average. So we usually look at them on x-ray daily to kind of see when they come together, and then eventually we see spit come out the tube, but average about 6 days. I don't know of any difference in outcomes with the azygous vein. I don't think it's a physiologic consequence to ligate it. I do sometimes clamp it just to make sure that it's not causing any flow issues down. I was taught by one of my partners to do that as a fellow, but I've never seen it cause any problems.
So TPN, Aaron, Dan, do you start them on TPN?
Depends on the size of the baby, and if they're already on TPN in the NICU, then we would continue it. I think if they're, we probably are pretty conservative here. Our standard approach to a routine type C esophageal atresia repair is to wait for 5 to 7 days and get a contrast study. And once we get a contrast study that shows no leak, then we start to feed the patient. There are certainly places, and maybe the practice in Pakistan is to start feeding much earlier. We have not done that.
So the question about clip versus ligature, you know, the controversy is whether or not the clips cause a recurrent fistula. Do they erode through into the trachea? And, you know, I don't know the answer to that because I don't know anyone who has done a randomized trial. People do one way or the other. So I think, and then we've even talked about what type of suture do you use when you ligate? Do you use a silk or a Prolene or a PDS? But I think, if you talk to people that have the most experience of thoracoscopic TEFs, they say that they have not seen a problem with clips migrating into the trachea.
Okay, so we have our presenter, Dr. Aziz, who wants an opinion regarding a difficult case. So Dr. Aziz, can you please share your screen and share your case?
Tried stopping to share, so hopefully you can do that.
Okay, Dr. Aziz, should I share my screen?
I think we can see the case now.
Yes, it is.
Wow.
So that, can you back up 2 slides? And there's nothing, there's no contrast getting through there.
Oh, is he muted?
Can't tell. I can tell you our approach with this would be to, as often is the case when we get complex patients like this, is to take them to the operating room with GI and surgery and ENT and do endoscopies. For this child, it would be the child does not have a G-tube, correct? So if we could not find any kind of opening there, we would probably put in a G-tube and decompress the proximal pouch. Because we have no idea how long the stricture is. It looks like it's a pinpoint stricture, but we don't have any idea. Typically, if we have a G-tube in place, then we would put the scope in retrograde. And oftentimes you can, if it's a very small length of a stricture, we can even poke a needle through to get across and then begin to dilate it before committing the child to any kind of a replacement or anything like that, and then do routine dilations.
So secondly, I want to ask any tips and tricks regarding how we can prevent these kind of strictures when we are doing primary procedure at the neonatal age?
It's a great question, and one of my colleagues is an expert basic scientist in bowel physiology and science, and I've challenged him to tell us why some kids get these strictures and other kids you can do exactly the same anastomosis and they don't. So I don't know that I have a good answer for you on that. Obviously, we try to make sure that there's good blood supply and that all the standard sorts of surgical avoid a stricture approaches of good blood supply and a large anastomosis and such. But some patients just form strictures, and it's very frustrating because it's hard to predict. But we're very aggressive with dilating these. And have had good long-term results, but sometimes they have to be dilated every other week for months.
And should we start dilatations prophylactically around the time of weaning, or once they develop symptoms, it should be started only then, the dilatations?
Yeah, it's a good question. Some of my partners and I disagree over whether you should get a routine contrast study after a repair. Now, we always get one on day 5 or 7 after a primary repair. I don't get one again unless the patient's symptomatic. There are other people who would get one 2 or 3 months later. I don't know, Aaron, what's your approach?
Okay, sir. Thank you, sir.
He's muted.
Yeah, but so I think usually I go based on symptoms, but if the child has any symptoms of not being able to tolerate feeds, or if it looks like it might be tight on the initial study post-op, then I get a repeat study, either when they become symptomatic or if it's very tight on the post-op swallow, then I would get another study in probably 2 weeks. Because once it gets to this point, it's much harder to address.
Thank you so much, sir, for the input.
Any other questions or? Okay. Well, thank you for inviting us.
Okay, thank you, sir, on the behalf of Children's Hospital and Association of Surgeons of Pakistan.
Well, we appreciate the opportunity to have the conversation, and as we said at the beginning, to learn from you and hopefully share some of the approach that we take. But it's someday I'd like to come to Pakistan, but it was very nice that we could do this by Zoom, and makes it all more easier to accomplish. So we appreciate that opportunity.
Thank you, sir.